All right, welcome to Quick Review RN. We're going to be covering our top NCLEX medications. We're going to be starting in our cardiac system, our cardiac folder, specifically our blood pressure medications such as Lisinopril, our Losartan, our Metoprolol, and our Amlodipine. I'm going to be giving you visuals for remembering your mechanism of action, med endings, etc. I'm going to be providing audio while you're commuting and on the go, and also provide typed info for our list memorizers, specifically with these different medications. All right, so I want to make clear that this is an NCLEX review. This video specifically focuses on high-yield NCLEX concepts and common nursing considerations. However, it does not include every possible medication detail or NCLEX question topic, so make sure that you understand what this video might be missing from the medications that you also need to put into your knowledge bank. Always continue studying from comprehensive NCLEX resources that you've been provided. So this is a page right here that is going to show you specifically the cardiac medication categories that we're going to cover in this section. And first of all, of course, we're going to cover our blood pressure medications. This is going to be our first video, but we're going to be covering a lot of these other videos over the next upcoming weeks. So make sure to stay tuned if you're interested in those at all. All right, let's get into our first medication here. So we have the medication Lisinopril. And what type of medication is Lisinopril? It is our ACE inhibitor, or our angiotensin converting enzyme inhibitor. Okay, we'll come back to that in a second. Okay, as far as Lisinopril goes, what uses do we normally see with this medication? Well, normally it's one of our first go-to meds for hypertension to decrease high blood pressure. It also might be used to help treat some other similar diseases such as heart failure, post-MI protection, and also our diabetic kidney protection as well. Okay. Now let's go back over to the picture. What I've got here is I've got an angel that's playing tennis, and that's to help you remember that it's dealing with angiotensin. Okay, angel playing tennis. And what's she doing in the picture? Well, I actually have her in a blood vessel. Okay, so we know it's going to act on the blood vessels. And it's playing and beating the angiotensin 1 tennis ball. Sorry, it was an alarm of mine. It's beating the angiotensin tennis ball back to help it be prevented from turning into angiotensin 2 or converting to angiotensin 2. And what's going to convert it? Well, if we think about the RAS system and anatomy, and if you don't remember a lot of this, just remember that you might need to go back. The lungs secrete or produce the ACE enzyme, or the angiotensin converting enzyme, that converts angiotensin 1 to angiotensin 2. Nothing happens with this angiotensin 1 until it's turned into angiotensin 2. So angiotensin 2 is specifically the part or the portion that actually causes the action that shrinks or specifically vasoconstricts the blood vessels, okay, causing that high blood pressure. And if you can release that or cause vasodilation by keeping the angiotensin 2 from causing vasoconstriction, then you can get some vasodilation, and it's systemic, so it's going to work on our veins and our arteries, okay? In addition, angiotensin 2 also causes aldosterone release, okay? Angiotensin 2 does. So what happens if we restrict angiotensin 2 from being created or from being converted to angiotensin 2? If we're preventing that, then what we see with lisinopril is that aldosterone release is lessened, and we're going to see more release and excretion of sodium and water through the kidneys. Okay? Just to reiterate and go back, because angiotensin 1 is not turning into angiotensin 2, the real form that causes vasoconstriction, okay? We're going to have vasodilation across the board, which is going to help with decreasing that blood pressure. It's also going to cause aldosterone release to be lessened. And since we have less aldosterone, we're going to have more sodium release and more water release. That might increase a little bit of how much you excrete as far as your urine goes, especially with sodium and water, but it's not like a diuretic, okay? It's not as intense as a diuretic. So keep that in mind. Side effects for this medication, okay? Important side effects to know and more specific to know. Okay, lisinopril is known for a dry, persistent cough. Okay, I've seen patients with this where they newly get on lisinopril and they have been coughing for the past couple of months, and then maybe I see them and I'm like, hey, how long have you had that dry cough? Well, a couple of months. Are you on lisinopril? Yeah. Well, you might want to talk to your doctor about that because it is annoying and it's not, it is a common symptom for specifically this medication. Okay. Another odd one, okay, is angioedema. Okay. With lisinopril and for my tennis angel, I gave her really large lips, reminding you that angioedema is possible. It's a rare side effect, but it can cause your lips, your tongue, and airway to swell, potentially cutting off your airway. Very, very dangerous. Need to go see a doctor right away. May need to intervene with an emergency escape to the ER there. Okay. All right. What's the commons that we're going to see with lisinopril? Well, we're going to see low blood pressure, okay? Especially want to watch and monitor our first couple of times taking this medication, making sure that they understand that they might become hypotensive, that their body might get used to this over time, but that they might stand up and fall over as they're trying to stand up and run, to their next activity. Okay, so making sure that we're monitoring, having them stand up, making sure that they're aware of to stand up first, take a couple of steps, and start slowly, okay? In addition, we talked about how we're going to decrease in our sodium, okay, in our blood because we're going to be releasing more sodium in the urine. What does that mean for our inverse sodium and potassium reaction? If we're getting rid of sodium, there's a small chance we might actually get high potassium with this medication. Okay? So keeping that in mind, making sure that we're understanding that, we might be looking at an electrolyte imbalance and monitoring for that. In addition, with our NCLEX pearls, one other thing that I would likely mention is that it can increase creatinine initially, okay? And what does that mean? Well, that comes from the kidneys. So we want to make sure that it's not affecting the kidneys too badly. So when they come back for their checkup, let's say if a doctor puts them on lisinopril, they're likely going to want their creatinine levels drawn at that time and make sure that their creatinine is functioning okay. With the kidneys, lisinopril is fine balance with kidney injury. It might be okay initially in chronic kidney disease, but as we're getting to more advanced stages, we might actually take it away. It might actually be beneficial in initial stages, and that might be taken away later in more advanced stages. Okay, so it's a fine balance, and of course we want to make sure that that we're monitoring their kidney function and how they're doing on lisinopril. Okay. Other things, anything else? Couple patient teaching bits. Okay. Whenever they're getting on a blood pressure medication like this, you want to make sure that they understand they need to be taking their blood pressure. Okay. They just need to be. Need to be taking their blood pressure on a regular basis. At home, make sure they have one. You can get one off of Amazon fairly cheap, or you can get a nice one off of Amazon for a little bit more. Different things like that. It's really crucial that they are checking their blood pressure so their doctor can see their trends. Also, changing positions slowly like we talked about. Avoiding potassium supplements is huge because potassium supplements and salt substitutes are regularly going to be potassium based. Okay, so if we have a chance of high potassium, we need to decrease those. Okay, and also in addition, they might want the salts, depending on what your levels are, you might want to be careful of salts too. So you might just need to be careful of both the salt substitutes and salt itself. Okay. And then last of all, again, just repeating, report any facial or tongue swelling immediately. Make sure that they understand that that's a possible symptom, okay, for this medication. Okay, so let's go ahead and get into the next medication here. We've got Losartan. Okay. It is an angiotensin II receptor blocker, which gives us a big hint as far as what's happening with that RAS system again. Again, if you don't understand the RAS system, it's such a big, complex system that we do need to understand before you take the NCLEX. So make sure that you take a look at that if you feel a little confused. All right, so what are the indications for our Losartan? We're looking at hypertension again, okay? That's the big one, hypertension. It's going to work similarly to lisinopril. We're also looking at other things such as diabetes, diabetic or nephropathy. We might use it for heart failure, certain heart failure types. It might also help with stroke risk reduction, which a lot of our blood pressure medication pretty much help with too, by lowering that blood pressure. All right, now what's our picture looking like? Well, Losartan sounds like Spartan. You'll hear that a lot. Losartan, Spartan. And it is an angiotensin II receptor blocker, which means we've got a Spartan holding open the blood vessels with his hands, keeping that vasodilation. Okay? He has a shield on his chest that has the number 2. Okay, he's going to block angiotensin II from getting to what is behind him, a receptor. Okay, so he's keeping angiotensin II from hitting the receptor site, which would cause what again? It would cause vasoconstriction, and in addition, what does it do with aldosterone production? Well, it's going to keep aldosterone from being released, causing sodium and water to both be sent out of the kidneys. Okay? Aldosterone keeps our sodium and our water from being released through our kidneys or from being excreted. Okay? So, what is this going to cause as far as side effects? Well, we've covered a lot of the same side effects as lisinopril here in this one. However, it's much less likely for Losartan to cause that cough. Okay, so a lot of people, if you get that kind of cough like lisinopril, you won't get it with Losartan. Okay. In addition, what other obvious side effects do we have? What's going to happen to their blood pressure? Low blood pressure. So we're looking at hypotension, dizziness, lightheadedness, orthostatic hypotension, which means we need to educate our patients on signs and symptoms of hypotension, signs and symptoms of orthostatic hypotension, and how to deal with it. Getting up slowly, moving slowly when standing up so that they can get their balance, make sure they're not getting lightheaded, to sit back down if they get lightheaded. Okay, very crucial there. With Losartan, you have a little chance of getting some mild edema in the extremities. Okay, mild edema. Maybe you can think about the Spartan's ankles getting a little swollen there, okay? Popping out a little bit out from under his arm or something. Okay, so it can cause some mild edema in the extremities. What is going to happen with the electrolytes? We talked about how we're going to probably see sodium decrease a little bit. And that sodium works inversely with potassium, right? So if we lower sodium, we might see an increase in our potassium, okay? And then one of the big side effects, maybe the biggest one, is angioedema. And why? Because even though it's very rare that you get swelling around the face or the lips or the airway, if it occurs, that is the biggest medical emergency you could probably have, is a compromised airway. Okay, so we want to make sure that our patients understand that, especially if they're taking it for the first time, to monitor that. All right, so we talked about side effects. Let's go to our NCLEX pearls. We're going to monitor our blood pressure. Okay, we're going to monitor frequently. We're going to have them monitor at home. Okay, get them to order something off of Amazon. It's really easy to do, and they need to be doing it daily. Monitor their potassium level when they come into the doctor. You also might want to monitor their renal function as well. Again, it can have some effect on the creatine as well in their renal system. Okay, so you can monitor their BUN and their creatinine. Tell them to avoid potassium supplements and salt substitutes, just like Lisinopril. Okay, it can cause an increase in that potassium, and it might already be a little bit on the higher end. Okay, again, it doesn't cause as much on the dry cough there, which is really helpful. And then also this one, just a little bit of information on that, on whether or not it's safe for pregnancy. They really consider it more safe to stop the medication and not to use it during pregnancy. Okay, so that's Losartan. All right, Metoprolol. What kind of medication, what type of medication is Metoprolol? It is a beta, what number? Beta 1 selective blocker. The way I like to think about this is beta 1, what's their one of? Heart, one heart. What's beta 2? What's their 2 of? 2 lungs. Okay, so that makes it a little bit easier. Beta 1, if you put a 1 on a heart, beta 2 for 2 lungs. Okay, and what's the indications for this medication? Well, it's going to lower blood pressure, so it can be used for hypertension. It might also be used for arrhythmias. Okay, it's a great one for certain arrhythmias, especially for things like AFib, and there's quite a few others that it can be possibly used for. It's going to calm the heart so that it can maintain a good rhythm, hopefully help with certain arrhythmias. Great med for that. What's another indication for Metoprolol? What about for a symptom you might experience? Chest pain. Yeah, it helps with angina. Okay? And the way that we're going to help with angina is we are going to look on this picture here. It actually says effect. Okay? Effect. If you look on there, it says it decreases heart rate. Okay, and it decreases heart rate. Why? Because it's going to keep the sympathetic response of the heart to actually become more parasympathetic. Okay, when those beta receptors are activated, those beta and alpha receptors, it causes a sympathetic response. And since this is the beta 1 receptor response, it's going to block that, so you get a parasympathetic response. So it decreases heart rate. It also is going to decrease our contractility of the heart, which means those ventricles aren't going to be contracting so darn hard, which would increase oxygen demand and the demand on the heart. Well, if they have heart failure, if they have arrhythmias, if they have angina, putting more pressure on the heart isn't going to be helpful. So this medication helps lower that effort of the heart, okay? It's going to cause decreased blood pressure and decrease oxygen demand of the heart because it doesn't have to work as hard, okay? So that's important to note. That's really, really important with metoprolol specifically, okay? Now, picture here, okay? Going back to the picture here, we got a metal patrol officer, okay? He's like a heart, character, but he's a metal patrol officer. He's in a metal patrol suit, and he has a stop sign that says slow down. And so you have a car that's in red, it says tachycardia on it, and he has to slow down. And then you have somebody in a normal rate who's able to pass easily. So we're slowing down the heart rate, we're slowing down or we're decreasing the blood pressure, we're decreasing that contractility of the heart, and that decreases the demand of oxygen. Okay. Now, what side effects are you going to see for this patient? Well, just like any other blood pressure medication, hypotension, dizziness, fatigue. Okay? Lightheadedness. So, again, orthostatic hypotension, keeping that in mind, telling patients that they need to avoid getting up and running out of bed like they usually do. Okay? Especially before they have a chance to check and see how the medication works for them. As opposed to vital signs, what vital signs are we looking at? Heart rate and blood pressure, okay? Because both of those might be low. Now, if blood pressure is low in the morning or heart rate is very low in the morning, what are you going to do? You're going to hold the medication until you get to the proper, until maybe a little later on, and you can check and see if the blood pressure's gone back up. A lot of times blood pressure will go back up as they're kind of getting ready for the day and stuff. Maybe, and make sure that your patient is checking their blood pressure and heart rate at home specifically. Okay, so that they don't take it on a bad day and it causes them to trip and all of a sudden they're in the hospital. Worst case scenario. One of the worst case scenarios, excuse me. Now, a couple other side effects to keep in mind. This one's really interesting. As far as their hands and feet, they might notice it be a little bit colder, okay? You might notice their hands and feet getting a little bit colder. Why is that? Because if you decrease blood pressure and the contractility of the heart, what's happening to the blood around the body? Well, it might not be forced as quickly around the body, which means that blood that's getting away from the heart is cooling as it's going out to the extremity. And then it comes back to the heart a little bit more slowly, okay? Cold and clammy hands and feet, okay? Now, going back to beta receptors, okay? Beta 1 is heart, beta 2 is lungs, okay? What medications are a beta 2 agonist? Okay, beta 2 agonist. So we're stimulating the sympathetic response for your lungs. Albuterol. Okay, there's a lot of medications that we can use that might have bits of albuterol or other things that are trying to open up our lungs. Okay, so if we have a lung patient, a respiratory patient who has bronchospasm, like asthma, and they need their bronchodilator, if we use metoprolol and albuterol at the same time, what's going to happen? They're going to work inversely against each other. So, don't use it if your patient's having a hard time breathing. Or hold off until you've treated it well enough and that they're experiencing it. Probably should be avoided as far as a blood pressure medication as much as possible in your regular respiratory patients. Okay? But if you have to use them together, definitely don't take metoprolol at the moment you're having breathing trouble. See if you can get the breathing under control for a while and spread those meds out very much so. Okay? Don't use them at the same time. All right. So, let's see here. So we obviously want to monitor blood pressure and heart rate. We want to make sure that they are getting proper cardiac output. Okay? You might even want to check the apical pulse before giving it as well if you want, especially if it's ordered. You also might receive parameters for heart rate and blood pressure, especially like systolic, but probably both. So making sure that they're maintaining that. You want to make sure not to give it to somebody who's experiencing any kind of shock, especially cardiogenic shock. You're not going to use for uncontrolled heart failure patients without making sure that they are within range, vital range. Severe hypotension, bradycardia, heart block patients, and then again, being really careful with your respiratory patients, making sure you're not giving it to an asthma or COPD patient, especially during an episode. And then if they're running into more respiratory episodes, maybe considering if we need to put them on a different medication, a different blood pressure medication. Okay? So that's some big stuff there. Okay? And then let's see if there's any additional patient teaching. Do not stop this medication suddenly because it can have a risk of rebound hypertension, angina, or MI. Again, it can help with angina. So if you're using it for angina and you stop it, ouch. You're going to be feeling like you need to go to the hospital for a heart attack. And this medication might have been keeping angina at bay. Okay? Take it exactly as prescribed. Change position slowly to prevent dizziness, and report new worsening shortness of breath or wheezing. Okay, so that's our considerations for our metoprolol. All right, moving on to our next medication, our final medication, amlodipine. Okay, what type of medication is this? This is going to be our calcium channel blockers. Okay, indication. Why are we going to give this medication? It's going to be for high blood pressure or hypertension. Okay. In addition, it's a really, really great medication for angina. Okay. What's angina again? Angina is our chest pain, specifically related to our heart, that occurs when our heart demands more oxygen than it's getting, and it's telling you, ouch, I can't keep up. Okay. So amlodipine, I've got a picture here of a cow because obviously calcium is very commonly seen as a cow. Okay, and I've got him in a dipping pool, one of those dipping pools where if you hit the target, he falls into the pool. Okay, kind of like at a circus. What is this child using to throw at the target? Well, he's using a pine cone. Okay, because amlodipine ends in pine. All right. So he's using a pine cone. He's throwing it at the cow. The cow goes into the dipping pool. A couple things to know about amlodipine and how it works. Okay. Calcium's used in a lot of things. Okay. And what we know about calcium and smooth muscle is that it's going to cause less release of calcium into the cells. So it's going to block the calcium channels that allow heart muscle, or sorry, let's say more specifically, smooth muscle. It's going to relax that, causing vasodilation. And more specifically, and I'm going to get into this real quick, this might be a little bit, you don't necessarily know this too well, but it lowers peripheral resistance more specifically on the arteries. Okay, so it causes vasodilation and lowers peripheral resistance, especially in the arteries. Well, what is that going to do when the heart is contracting? It's going to cause the blood flow to more easily get out of the heart. Okay, so the heart doesn't have to press so hard to get it out of that left ventricle and into the rest of the body. Okay, so that decreases oxygen demand, which is awesome. In addition, it's going to help bring more blood into the coronary arteries because I believe that it also dilates slightly those coronary arteries, allowing more blood flow into it. Okay, and that's actually how it helps with the angina specifically. So it lowers peripheral resistance by causing that vasodilation into the arteries. In addition, it's going to decrease the myocardial O2 demand because it's giving blood flow back. In metoprolol, it worked by just decreasing the effort the heart had to do. In this specific instance, it's doing a little bit of both. It's decreasing the peripheral resistance, okay, and decreasing myocardial oxygen demand, okay, because it gets blood flow to the heart. I want to make sure that you understand that very clearly. So make sure to kind of listen and go back if need be, okay? Now, let's go to the side effects real quick. What are we going to see there? What do we need to monitor? Hypotension, dizziness, lightheadedness, okay? Orthostatic hypotension, making sure they don't get up and move too quickly, things like that, okay? In addition, calcium channel blockers are a little more known than some of our other medications we've covered today for swollen feet and ankles and having more peripheral edema. Okay, so calcium channel blockers are a little more known for peripheral edema in the ankles and in the feet and in the hands, things like that. Okay. In addition, if it's kind of causing more of that vasodilation in other places, we also might see increased flushing of the face, so warm red face. Okay, it's opening those peripheral blood vessels, so we might see a red face. Okay, and then also there's a chance of reflex tachycardia. Okay, so some considerations to kind of keep in mind here. Obviously, we need to monitor the blood pressure and the heart rate. Okay, assessing for peripheral edema. Okay, and then in addition, do not stop abruptly because you might have reflex tachycardia and increased blood pressure. Okay, contraindications, severe hypotension. Again, if the patient should be taking their blood pressure morning and night. If you're a nurse, you should be taking their blood pressure. Making sure at least they take their blood pressure in the morning and things around the time of the medication. Okay, but yeah, making sure that they don't get hypotensive with it. Making sure they're responding well with it. Also, don't give this if they have cardiogenic shock. Okay, and in addition, severe aortic stenosis. Okay, some of the obvious things that you should, not give this medication for. In addition, we talked about the side effects, so we'll move on from there. Patient teaching. Teach them to take their blood pressure at the same time each day and their heart rate. Okay, changing positions slowly. We talked about that to prevent dizziness and falls. Report swelling of the feet and ankles, maybe even their flushing as well. And do not stop suddenly. Make sure they consult their provider if they feel like they want to get off the medication or if they're complaining about some of their symptoms. Okay, so that is the end of amlodipine. All right, guys, so that's the end of our blood pressure medications that I'm going to cover in this section. Again, you can look at this slide here, and we've got a bunch of different other medications we're going to be covering in the upcoming weeks. So if you feel interested in learning about some of those, feel free to stay tuned. All right, guys, so that's the end of my video here on blood pressure meds. I want to make sure that I encourage a little bit of participation here if you guys have any more knowledge about the things we've covered today. If you have any other NCLEX pearls, please comment those down below. If your professor's pushing you that they need to know something specific for the NCLEX based off on any of these, comment below. It's going to provide a really good index for anything else that I haven't covered in this video or any other adjustments you'd recommend. Also, in addition, if you've had any other patient experiences, if you're a nurse that's seen some of these, if you have seen this in your clinicals or other experiences, please share those below so that we can kind of hear a little bit more about how you've seen these meds function in the real world. Thanks so much, and we'll see you in the next video.